at this point now, it's almost how much time you have to begin treatment. At our institution, and I think this is going to occur now in the rest of the world as FLT3 inhibitors are approved, which FLT3 inhibitor are you going to use? Right now, we can put a patient on a FLT3 inhibitor trial up front. Maybe that's a better drug. Well, they've got to be stable enough for that choice. To get on a trial, you've got to delay a week or two or several days to get results back from next-gen sequencing or something to decide if they're appropriate for the trial. If they're not stable, just quickly give them Midas Torrent. Well, there are now 2 drugs that are going to be approved sometime in the next 12 months. One has already been filed, is at the FDA. The other one has just announced a positive phase 3 study, so they're going to be filing. So all of a sudden, even though it's off-label, the drugs are going to be approved for relapse setting. In the US, there are going to be kind of decisions starting to be made about, in the newly diagnosed patient, do I want to use on-label Midas Torrent, or is this patient going to do poorly enough that maybe I should look to doing something more off-label, and we may consider that. And then the usual performance status to some degree. But really now we're looking at the mutation profile. The patient who's got a high allelic ratio FLT3 mutation and an NPM1 wild type, they're going to do poorly. And so is Midas Torrent the best choice for that? I think we've been having great results with Midas Torrent in the large bulk of the patients, but there's a subset that are doing poorly. Do we need a more targeted FLT3 inhibitor for that? Well, those drugs are becoming available. And so algorithms are now getting more complicated as to where we go with those patients.